Good afternoon, and happy Rare Disease Day. I'm Jerry Vockley. I'm the director of the Center for Rare Disease Therapy here at the Children's Hospital, and we have a very special program today. We're going to speak to my colleague, Dr. Jane Breck, who recently, like just a month ago, retired after over 50 years of service to Children's Hospital and the PKU Clinic. So we're going to have, I can guarantee you, a fascinating conversation about her view of the evolution of treatment of that disease and her thoughts on where things are going to go in the future. Before we do that, I'm going to play a little.
What is a rare disease? It's any disease that affects less than 200,000 Americans. But around the world, 300 million people have a rare disease. There are more than 6,000 rare diseases, and 72% of rare diseases are genetic. 7 of 10 rare diseases begin in children. Living with a rare disease can be difficult for children and their families. That's where we can help. At UPMC Children's Hospital Center for Rare Disease Therapy, we have experts with years of experience treating rare diseases. The diseases are rare, but we fight them with the best-known treatments and research new treatments when none exist. We also will treat your child as an individual and with compassion. You and your family are not alone. We're here for you. For more, go to chp.edu/rarecare.
All righty, and we're back. Thanks to our media relations team for putting that together for us. So as I said, we're here for a conversation that I've been looking forward to for a long time, ever since we decided that this was a great way to spend our Rare Disease Day time with you. For those of you who don't know about PKU, I'm going to give you like the 30-second story because I don't want to take any time away from Dr. Breck. PKU is a disease that it makes the body incapable of metabolizing the amino acid phenylalanine. Amino acids are part of all of the protein that we eat, and therefore the protein, which is broken down in the intestine to its amino acids and generates phenylalanine, will lead to the toxic accumulation of this amino acid in the blood. The results are devastating if left untreated. Children have very poor neurodevelopment and can have difficult to control movement disorders as they get older. Fortunately, the disorder is now identified by newborn screening and has been so for about 50 years. And treating those children is in that after the identification by newborn screening, it has up until fairly recently just been a matter of juggling their diets. And so we've had not a lot of tools for taking care of these patients. And enter Dr. Breck into the picture. Dr. Breck joined the staff here at Children's 51 years ago. Did we decide? Mm-hmm. 51 years ago.
51 years.
But before we get to that point, I'm going to start off with asking her some stories about her older self, because I know when you started medical school that you looked around the room and didn't see very many people who looked like you. Is that correct?
Absolutely. When I applied to medical school, which was Jefferson Medical College at the time, there were 7 women in my class and 165 men. And luckily, school was encouraging women to apply, so they treated us royally. I didn't feel any discrimination. I didn't feel any harassment at the time, and I felt welcomed. The class graduated, and from there, I decided, let's go into pediatrics. I had some mentors that were wonderful. Women in pediatrics was very rare at the time. And now you look around and women are in medicine, women are in leadership positions. There are about 16 women deans of medical colleges in this country now. So then it was very different.
And when you came to children's, then you were interested in developmental pediatrics, and had you ever heard of PKU in medical school? Did they teach you that back then?
I probably wasn't listening because
some things never change.
because when I finished my medical school training, I decided, what did I want to do? I wanted to take care of those unfortunate handicapped or individuals with disabilities. So I got some training in, at the time, called mental retardation. I took a class that was 100 hours just focusing on mental retardation. And then I decided I'm going to work in a developmental unit. So when I came to Children's Hospital, I applied to come into the developmental unit. And there is where I saw my first PKU patients, because late treated, late diagnosed, the patients who came in were cognitively impaired. So I really didn't see a patient with PKU who was functional and was developing normally.
So how did you go from there to taking over the PKU Clinic?
Well,
go ahead. You can say it. I won't make any excuses for us.
okay. There were two physicians who were running the PKU Clinic. One decided to leave and go into private practice, and the second one was called to be the executive medical director of the Children's Institute, known as the Home for Crippled Children at the time. And there I was, the third doctor seeing PKU patients, so I fell into it. Like so many things, serendipity.
And you realize what happens when you're making plans. And you told me that the lone geneticist of the hospital at the time didn't want to deal with those patients.
Well, nobody wanted to deal with the PKU patients. The geneticist was seeing mostly patients with Down syndrome. Endocrine didn't want anything to do with it. Neurology didn't want to see PKU patients. So we stuck in there like an independent little digit. Nobody wanted us. So I just started seeing patients. And at the time, maybe there were 40, 50 patients with PKU. Majority were impaired. And there was only one dietary treatment for PKU at the time, which was a amino acid mixture without any phenylalanine. We call it FAAP. So the treatment was almost non-existent.
Were you, was Pennsylvania screening for PKU then? Had they started yet?
Pennsylvania started screening in 1965. But prior to that, because the metabolism of phenylalanine produced phenylketones in the urine, we used to do what we call the diaper test. That's before your time. And if the diaper turned,
but I do know what it is.
Yeah. If the diaper turned blue after the test, then we knew that there were phenylketones in the urine, which meant phenylalanine in the blood was elevated, and we had to do something immediately, or it would cause damage to the developing brain. And that's why we were so happy when Bob Guthrie was doing filter paper blood spot testing for cancer, decided after finding out that his 18-month-old niece had PKU, he decided to develop a filter paper blood spot finger prick or heel prick test for newborns to test for PKU, and also to monitor and follow the patients with PKU over time.
They still call that test the PKU test. You walk into any nursery in the country and ask the nurse, has the baby had newborn screening? They'll look at you like you're crazy. And then they'll say, the PKU test. Oh, yeah, we did that. Even though they're doing 50 disorders now.
Right. It's just amazing, isn't it? That 4 drops of blood only used to diagnose PKU 50 years ago now is used for so many other tests.
For those early years, you weren't completely by yourself. You had a dietitian that you worked with. Tell me about her.
Well, first to say that treating PKU is a team approach, and you usually have dietitian, social worker, and possibly someone in genetics. But at the time, the geneticist wasn't interested. So being patients had to be early diagnosis, bring the patient in, and as soon as possible, which could be 4 weeks later by the time you located them, got the parents, called the PCP, got everybody to come in and to children's. It was not as early treated as it is now. Very different now.
And you did all your management using the Guthrie spots as well?
Yes.
To measure Phe?
Mm-hmm. And we had community health nurses all over the state going into homes to prick the baby's heel, put it on the filter paper and mail it in. And parents were never taught at that time to do any of the blood spots. Now the parent can do it and send it in anytime, and if you weren't happy with the result, do another one as soon as they heard the results. So that's changed dramatically.
And how did you come to grips with the field? You know, you were diving into something that was completely new to you. Who did you turn to? Who did you look to help you understand the disease and manage these kids?
Well, a few books on genetics, helpful. There were some mentors that were wonderful clinicians, and Dick Koch on the West Coast was very helpful. Dick Koch felt very strongly that once a medication was developed for PKU, that everybody should be on that oral medication for PKU. He was the one who said, continue treating for PKU with dietary restrictions. Don't allow the patient to have food high in protein and high in phenylalanine. And nobody was listening to him. They were saying, well, once the brain is developed, then no harm can be done. And, oh, isn't the brain fully developed and the size of an adult brain by 6 or 7 years of age? And so the going theory was, it's okay to stop treatment for PKU when a patient is 5, 6, 7 years of age. And that was found to be very wrong. Mm-hmm. Things have changed a lot.
Things have changed a lot. Any patients from back then, in particular, or families that stick with you, that have been helped you maintain your enthusiasm for treating this disease?
So many. I think treating any metabolic disorder really focuses on the support that a family provides. Our patients who did the best, the patients whose families accepted the diagnosis, got right into what we should do for treatment, and no matter what, we're able to say, you can't eat that. There are some families who felt so sorry for their child with PKU that they had a hard time restricting food that was high in phenylalanine. We found grandparents were very important, because there were some grandparents who couldn't believe that there was a disorder that you couldn't see. The child looked fine, acted fine, did everything that other children did, and then grandparents would give little snacks high in protein. So we had a hard time with the extended family. But as far as any particular family that stands out, no, I would say there's so many families that stood out. They're the families who accepted the diagnosis and said, we're going to beat this. That attitude was then transferred to the child. The child said, I'm going to follow the diet, even though I look around and my friends are eating high protein foods and they go to McDonald's and they have a hamburger, but I'm going to have 6 French fries. That's all I can have in my diet. And then these same children who were so vehement about sticking to their diet, they're now so accomplished as adults. So those are the ones that really make me feel honored that I was able to help the family understand the disease and the child to follow through.
There was a steep learning curve, but you mastered it, and you had this cohort of patients that I think it's probably fair to say wasn't generating a lot of interest outside of the few physicians around the country and world who were taking care of them. Very different now, you mentioned. How have things changed, and when did that start?
Well, things are different because there's a team, and as I said, the team is made up of the dietitian, genetic counselor, social worker, nurse care coordinator, and I must say the most important person on the team is the dietitian, because she's the one who contacts the family with the results of the blood test, lets them know that adjustments have to be made, works behind the scenes, they email each other, she calls them when things aren't going right. And the fact that I have been the director of the PKU program, director in name only, really the team is what relied on to do most of the heavy duty lifting.
I think any good treatment team that has a good director knows that the director lets the team do what they do best. You certainly fall into that category. Your team members have always just been incredible with those patients. But I know I got here about 18 years ago now, and our then department chair, when he was telling me about the kinds of things he thought needed to be done here, said, well, we got this thing, this clinic, this PKU clinic. Do you know about that disease? And I said, yeah, maybe. Well, they sort of don't have any home. Would you be interested in having them in your division? So sure enough, all of a sudden you're now part of what was then called medical genetics. You don't have to answer, but I'm interested in what you were thinking. What was that going to be like? Now you had somebody who was also interested in the disease, and maybe could either help or get in your way depending on the circumstances.
My first reaction was, thank goodness. Because you came not only by yourself, but you encouraged a lot of people on a team to come, laboratory researchers. Then you set up the department and hired multiple genetic counselors. So I thought, here is the way to do things, to really have the support of many people on the team. I think too that when you came, I was really interested in picking your brain. And at the same time, I was interested in continuing to do what I'm doing. But you talk about this person who is a developmental pediatrician, surrounded by geneticists, so that it was a little unusual. And in a way, I was grateful that I didn't get sent somewhere else.
Well, so am I, Jane. I do remember as I said, worrying that I was going to walk into what was then the combination clinic office workroom. I mean, it was just piled high with things in our Cole, who was then the dietitian, and just didn't know what sort of reception I would get, and I'm pleased to say you welcomed me with open arms, and I do think it was the beginning of a great working relationship. I will say, however, that I'm pretty sure you set me up. Because as I started walking into rooms, when I would see the occasional PKU patient, they'd all look at me and they say, "Well, we hear you do research. We want to get involved in PKU research. You know, we want to have an opportunity to participate in it." And I said, "Well, I don't do that." And after about the fourth or fifth patient who said that, and somebody told them that I was involved in research, Dr. Breck, I said, "Well, I guess we have to figure this out," and that was the beginning. They were just getting ready to start the trials for sapropterin Kuvan, and we became one of the first sites for that clinical trial. How did that feel to you? A drug, something that besides just saying no to patients about eating, to start providing them with some additional options for care.
That was very exciting. And not only that, but one of the things that came out of that was the pharmacy company that makes the sapropterin Kuvan asked me to be a promoter, but at the same time gave me the opportunity to go around the country and give lectures. And they supported me, so of course I had to say that at the beginning of each lecture. I said, and I am supported by the company that makes Kuvan, but let me tell you about, and then I had multiple lectures that I worked on with the company. I worked on a lecture on PKU in the brain. I worked on a lecture on PKU and lifestyle changes, a lecture on how PKU affects learning, how PKU affects decision whether or not to have children. And so I see that as a wonderful opportunity. I enjoyed those lectures. I was welcomed. I was treated like a visiting royalty, and I got to travel. And I can remember giving lectures in Portland, Oregon, and in Miami, Florida, and in Tucson, Arizona. And I wanted to be out there because I wanted to get the message out, but I also wanted feedback from the people I was talking to in these clinics. Because one of the biggest problems was that the clinics weren't all doing things the same way. Mm-hmm. And I guess you know that too.
Yeah, it's always a struggle when you have 20 people with 20 different ideas and about how to do things. I had a friend in college who said, "What we need is a system. What we have is 7." And sometimes that's the way it is in genetics. You had an opportunity to work with now a number of biochemical geneticists who have come to join the group, as well as our laboratory geneticists who provide the critical services to help us manage the diseases. How do you feel your treatment is different now than it was 50 years ago?
Very, very different. Let me just step back a minute, because you asked about my interaction with biochemical researchers and other researchers. Mm-hmm. And Steve Dobrovolsky, I have to mention his name because he so interested in some of the biochemistry and trying to associate the biochemistry with changes in the patient. Rob Nichols, who was actually really exciting to hear talk about creating an animal model, because up to that time, PKU research was being done with mice. The PKU mouse was used and fed high phenylalanine, put on restricted diet, and then examined by pathology and biopsy. So trying to develop an animal closer to the human model was really an exciting idea. And Rob Nichols, I think, was someone who inspired me, because then I had to learn about pigs. And then let's go back to the second part of your question. And that was, remind me what that was. Since
oh, you're going to ask me? Oh, come on. I think we started off with what are the biggest changes in the 50 years that you've been doing this?
Changes in treatment are the biggest changes. And when I started, there was one formula and a list of foods you couldn't eat if you had. Now there are multiple formulas. Amino acid blend without the Phe is also made into food. It is presented in pouches that look a lot like drinks that kids drink in high school. So you're drinking from your pouch. Kids don't have to know that's your PKU formula. Then low protein foods are more readily accessible, since restrictions are mostly for the protein foods, and we call free foods those that have no protein. Unfortunately, those are mostly sugar. And then the low protein foods, fruits and vegetables, except for those a little higher in protein like legumes, the peas, the corn. So they have to be counted and measured. But availability of foods, low protein foods, various forms of the formula, even capsules that were loaded with powdered formula for people who wanted to take 40 capsules 3 times a day, but that wasn't very popular. But no, the treatment for PKU now is so much better. You talk to families and they just are so appreciative that there are so many forms of phenylalanine-free foods. But that's exciting.
Before we move on with my conversation, I will just take a second to remind you that we're talking with Dr. Jane Breck, who's been the director of the PKU Clinic here for 50 years or so, until her retirement at the beginning of 2022 as part of our Rare Disease Day celebration here at UPMC Children's Hospital. I'm Jerry Vockley, the director of the Center for Rare Disease Therapy and the chief of the Division of Genetic and Genomic Medicine, and this, of course, is Dr. Jane Breck. Just so you know, if you're online and you want to type in a question, you can do so. There should be a white box down there somewhere that you can do that, and the moderator here will send it over to me, and we can pose that to Dr. Breck as well. I will also take the opportunity to let you know about something that I find very, very exciting. The family of one of Dr. Breck's very first patients in the PKU Clinic has started a fund at the Children's Hospital Pittsburgh Foundation in Jane's honor, and I think it's called something exciting like the Jane Breck Fund or something like that. Anyway,
PKU Fund.
The Jane Breck PKU Fund. That's right. We got all the important words in there. And the goal of the fund is to raise enough money to endow a position for a trainee to come to Pittsburgh and learn about PKU and ultimately go back out in the world and either help treat or study PKU and move the field forward. So if you are at all in a position to do so and would like to, you can go to the Children's Hospital Pittsburgh Foundation. If you just Google that, you'll get there and look for the Jane Breck PKU Fund, and please be as generous as you can. I sound like public radio, huh? But just a wonderful way to remember Dr. Breck and all her contributions to the care of PKU families over here for 5 decades. Oh my gosh, what a devotion and what a devoted care provider for our families. Back to some questions. What was the most exciting thing that has happened to you in your career? What do you find that has been the thing that looking back on it, or maybe it's now, you see as the thing that really excited you the most?
That's easy. Teaching.
Oh,
One of the things that I love to do is have students, medical students, genetic counseling students, residents, master students from programs at Pitt come and observe PKU Clinic. And it's done best by showing how it's done. Even though I like also to talk and lecture, I think it's the actually allowing to shadow me and to hear how parents of babies with PKU or preteens and teens with PKU react to coming into the clinic. Because coming into a clinic when your levels of Phe aren't where they should be, because we love to keep the levels so there is no risk of brain damage. So those levels have to be very narrowly kept. If we're using milligrams per deciliter, they have to be between 2 and 6 milligrams per deciliter. And so when they have a blood spot drawn and they get the results and it's 15, then they think, oh no, I've got to go into clinic and face Dr. Breck, and she's going to say something about what can she do to help bring the level down. I usually throw it at them. What can you do? What do you think you could do to have better control of your PKU? Because then they're telling me something that might be possible. If I tell them what to do, they're going to shrug it off, just telling me that. But if I pull them into the decision making and they say, well, the first thing is maybe I shouldn't have that ice cream I have once in a while, or maybe I should do more blood spot finger pricks because I've been high lately, and if I do more of them, then I'll know I need to change something in my diet. So I think that's one way. That's very exciting to get them involved. That's probably one of the most rewarding. That and teaching not just the students, but teaching the patients too.
And you've had your share of students over the years. That's for sure. You could bring one thing to the field tomorrow. One thing to help your patients or the staff, whatever. What would it be?
I have to look at what's going on with my patients and see that the majority of patients with PKU suffer from anxiety and depression. And this happens because their Phe levels are high, affects the part of the brain that controls emotion, decision making, executive function, part of the brain, and causes irritability, anxiety, sadness, depression. And I really think that that needs to be addressed in a stronger way than we have in the past. In the past, we've given them a questionnaire. It's a pretty standard questionnaire for teens with depression, PHQ-9.
We're starting to get some questions. Keep going. I'm just going to take a look at them.
And one of the things that we ask too is that they fill out a questionnaire looking for symptoms of toxicity. Are you irritable? Do you have trouble getting along with your relatives? Do you have difficulty making decisions? Do you have problems with your short-term memory? And then they check off those things that bother them. And so many of them have effects of toxicity, and so many of them have anxiety and depression. And this is one of the things that hit me the hardest this past year when we had a patient attempt suicide. And I realized that we're probably not addressing that, and I would love to have psychiatric input into the clinic. I'd like to have maybe the psych residents rotate through the clinic, and maybe a few more in-depth tests, and our psychologist more involved.
It's troubling in a way, because we talk about the need in complex disease, and PKU certainly qualifies to have multidisciplinary teams, and our medical reimbursement system makes that very, very difficult. Our insurers don't like to pay for multiple doctors. They think you should be able to do it all, and if anyone can, it's you, Jane. But it's a prickly problem, and it would certainly be terrific to be able to solve that. I've got a couple of comments coming in through here. I recognize one of your old patients saying, Dr. Breck, do you ever think we'll cure PKU?
Oh,
There's a low what was that? Would you? Well, for me, it would be a curveball, not a tennis racket.
This is a great question. This is a great question, because I'm sitting next to someone who is going to be involved with the research that someday may cure PKU. If you think about it, PKU is a missing enzyme in the liver. So how can we replace that missing enzyme? Well, one way is to transfuse liver cells from a healthy liver into someone with PKU, so that they can create the enzyme, which then can do the work of metabolizing the phenylalanine. Well, we had our first patient had this procedure done, and it went very well. But over time, those liver cells did not reproduce themselves, so we ran out of the liver cells that were doing the job after less than a year. So the surgeon who did that procedure said, well, we should have put in a couple more million liver cells. And someone else said, well, why don't we just give the PKU patient a liver transplant? And I think you had some experience recently with that, and you also had some feeling that that's not a very practical thing to do.
Well, it's tough. Any procedure that starts with step one, remove liver, is you have to think twice about it. However, you're right. We had a patient in our center here have a liver transplant, and has been extraordinarily happy with it, because she had been unable to control her PKU any other way. But
you have to say, she had to go on anti-rejection drugs, which in themselves may have some side effects.
Yep. So. Same thing is true with the liver hepatocyte, the liver cell transplants, and of course there's gene therapy, and there are now two active trials, and probably another one starting up soon. So I'll take the liberty of saying, yeah, it'll get there, but I don't think it's going to be the answer tomorrow.
And we have to mention that we have an injectable drug, and that injectable drug, known as PEG-PAL, pegylated phenylalanine ammonia lyase, which was not the missing enzyme, but it was so close to the missing enzyme that it was metabolizing the phenylalanine. How is that coming along?
Well, that's been approved now for 4 years anyway. I think it's about 4 years, and it is a change in the paradigm, because with that drug, unlike Kuvan, which, as you know, doesn't work for everybody, pegvaliase has the potential. That's the generic name for the approved drug. Has the potential to be to work for everybody. It is not without its own problems, though. It is an injectable. It requires everyday injections, and they're relatively large volumes. So there definitely are unmet needs still, and I think it's obvious that that's the case when you see all the clinical trials that are out there for treatments of PKU. We do have probably a half dozen of them going on here in the Center for Rare Disease Therapy, and it's really I think a testament to the recognition that there's such a need for this disorder. I also have a comment here from the family that has started the fund in Dr. Breck's name. I don't know, am I allowed to say? I guess I'm allowed to say his name. The Reese family, and they note that there are matching contributions made to the endowment fund. So that if you are see, I really am sounding like public radio now, right? You get dollar for dollar match. It's going on right now. I listen to it all the way in to work. But you will get you'll get your donation matched and add to the fund. The goal here, I'll just explain a little bit, is to build up a large enough amount of principal at the foundation that we will be able to use the interest that we make off of that in the coming years to support training for someone in PKU, and in the meantime, we'll use whatever proceeds come from that endowment to help out with other operations in the PKU Clinic. Families who need formula, who are unable to purchase medical foods, who have other needs, we'll be able to help them out with those.
And I want to shout out how grateful and honored and humbled I am for the Reese family.
Absolutely.
Yes.
Oh, this is an interesting question, Jane. What do you think is the most important thing a patient or family should know or bring to them when they're coming in for their PKU appointments?
Well, we request that they bring in 3-day diet diary, because when we see the patient, we have blood drawn, and the blood is not just to check the phenylalanine level, but it is also to make sure that everything else is healthy, the liver, the kidneys, that they are getting adequate iron, so that they're not anemic.
Bring this over here to me so I don't have to keep pushing it in front of you.
One of the things that we ask them to do is to bring in the records of what the child has eaten for 3 days, or the young adult has eaten for 3 days prior to the appointment, and that doesn't always happen. But we remind them, and we send them diet records so they can fill it out when they get their appointment. So what else should they bring to the clinic visit would be their questions. A lot of parents are very good on the internet, looking around and looking for ideas and recipes. So if a family finds a recipe for a low phenylalanine food, we'd like them to share it, and some of them do. Also, there are families who go online and connect with other families. So we encourage that. I think that's very helpful, because there were 3 families in one area in Western Pennsylvania, and they connected with each other, and they were so enthusiastic they decided to set up a summer camp, a 1-week camp for families and children with PKU, and that was so successful. That hasn't been done lately, but there are national camps for individuals with PKU where all the foods are provided by a special group of chefs, and they're all low protein foods. They get to share experiences. They have games and camp activities. So I'd like that to happen more often. Connect with each other.
He asks, what is one way we can better advocate for PKU and help spread advances?
Well, advocating is trying to get more support, and support can come in many ways. One is financial support, and support for the expensive low protein foods could be done through the Pennsylvania Department of Health. And in Harrisburg, I know there are a lot of expenses that the governor is trying to meet, and we have to be louder about getting support for foods that our patients require.
So to be clear, in Pennsylvania, we get coverage for formulas in a limited spectrum of medical foods, the low protein, low phenylalanine foods that our patients need. But it by no means is an exhaustive list, and just in case you're looking for a cause, it doesn't spread out to any of the other diseases that we treat that are very similar in flavor to PKU. So I agree completely that advocacy in Harrisburg and even at the national level is something that you have the wherewithal to do that. Can be very helpful. There's a bill that did not get passed called the Newborn Screening Saves Lives Act. Got hung up in politics, and now hoping to be able to attach it instead to the general funding bill, the budget bill, in the current congressional session. So contact your representatives and your senators and advocate for those bills to be passed.
One thing at the national level I have to mention, and that is that support for families with PKU used to be very regional. And there was a wonderful man who had family members with PKU, and he was a dynamic organizer. And he and a woman named Christine Brown set up the National PKU Alliance. And this NPKUA is now responsible for a lot of spreading the word, because the one thing we talked about advocacy, you can do it better the more support you have, the more people behind the advocacy. And Christine Brown has she has developed a yearly PKU conference, and not just for physicians, nurses, dietitians, but families come to these conferences. And because of COVID, the conference was canceled last year, but it is going to be held hopefully this July. And so anyone who's interested can go on the NPKUA website and look for the information about it. Also, the NPKU website puts a lot of information out about how you can raise money. People hold special auctions, they hold special events, and you can get an idea if family wants to do this, they can sign up, or they could even connect with other families at the national level.
Absolutely. A big shout out to Christine and the NPKUA, whose website I believe is just npkua.org.
Right.
Go to it and consume as a PKU consumer. Speaking of COVID, let's see. Megan asks, patient-facing careers can be challenging as a physician. How do you prevent burnout, or how did you prevent burnout? Because now I know you're sailing. Well, maybe soon.
You know, it's always important to have hobbies. And one of the nice things is that I now identify myself as the retired physician who spends her time sailing, gardening, reading, traveling, hopefully. And yes, there are a lot of opportunities to prevent burnout. I think socializing is a big way to prevent burnout. Even if it's just virtually with friends, in touch with friends and relatives, texting, and then that extra nap sometimes helps.
I'm a big proponent of naps. Matthew wants to know if you can briefly describe how a high Phe level can affect decision making.
Well, if you think of decision making as using part of your brain that requires organizational skills, and if you realize also that an elevated Phe level affects organizational skills that have to do with memory, so decision making requires organizing, looking at options, trying to decide the importance of the various options, and sometimes you cannot do that. The higher the Phe level, the more scrambled your brain is, and some patients like to describe it as brain fog. They say that some of them, until they get their levels down and realize, wow, I can think more clearly. I'm able to make more decisions. My boss isn't telling me what to do 3 times because I keep forgetting. Then they say, oh, I should have done this years ago, bring my level down. But they couldn't, or they weren't aware, or they wanted to come back to clinic and hear about the new treatments and the new medications and the injectable, and suddenly their brain is no longer in a fog.
Question here. A listener is asking, is PKU identified in prenatal screening, genetic screening?
It's not normally identified. Some people feel that you can look at the DNA, the changes that go on in the gene that controls the production of the PKU enzyme. A lot of things are happening prenatally. I mean, most exciting, of course, was the prenatal surgery that happened not that long ago that made national news. But your experience, have you had anyone who has wanted prenatal diagnosis? Because prenatal diagnosis is usually done for a serious disorder that's life-threatening and may result in terminating the pregnancy, whereas that's not the case with PKU. It doesn't justify it.
I think that from a practical standpoint, if you want to know in advance so you can prepare yourself, that certainly is one reason to do a prenatal test, which I agree is DNA based. You can do an amniocentesis and measure phenylalanine in the amniotic fluid, but it's not going to be very high because the mother cleanses the baby's bloodstream. And we can get the newborn screen back so quickly these days that we can intervene in as rapidly as is necessary fashion.
Those would be questions that someone who's already had 1 or 2 children with PKU want to know, because then, as you know, the genetics of PKU and the recurrence rate, maybe they would like to hear you explain it.
Well, I'd like to hear a little bit more from you. We'll come back for a primer on genetic counseling. And in fact, you can go to the CRDT website, and there are 2 lectures there by a couple of our genetic counselors that talk about genetic disease and review things, questions like that.
Inheritance.
So, yes, indeed.
Recessive.
So you have to have both parents be a carrier, and once you know that, the risk is 25% for each pregnancy. You can go to the website and listen to those lectures. Couple of questions. Everybody here really wants to know what do you think is the most promising therapy out there right now in development? What are you watching? What are you most excited to have been a part of as you saw yourself coming to the end of your active treating career?
Well, I guess Palynziq, which is the injectable, most exciting right now. something that talk about when we say, when will there be a cure for PKU? We look at gene therapy, and we say, if you can replace the gene that's not working properly or is absent, then that's the most exciting way to cure PKU. From your point of view, what's the time frame for something like that?
I hate to try to predict the future. You know, I say my crystal ball doesn't do too badly for a couple, 3 years, and after that, it definitely becomes cloudy. I will say that I think that in the coming 5 years, certainly we will have lots more options available. And that may be gene therapy, but it may also be a combination of a couple, 3 other orally administered medications that will bring your Phe level down to as low a level as we need it to keep you healthy. And so I think that we'll be transitioning in this field for 20 years, because we're not going to be treating babies for a long time with any of these, with some of these medications, and we have adults who are ready to dive in and get something like gene therapy right away. So it's definitely an exciting time in the field.
And there are other areas too, such as the microbiome, where if you could prevent the Phe from being absorbed by the gut, so that may be another option.
Which is a clinical trial that's ongoing now, where with an engineered a probiotic that will digest the phenylalanine in your intestine before you have a chance to absorb it. So if there's a way of getting the Phe down, there are smart people out there identifying it and trying to monetize it. Gotta love capitalism, but it does drive things forward. And right now, PKU is really at the leading edge of genetic therapy development and technology.
There was another part to the question, which was how to get the message out there. And often organizations will get the message out there by having public service announcements. There was a public service announcement yesterday or early this morning about a rare disease, and its incidence was 1 in 10,000. And I looked and I said, same as the incidence in this country for PKU, 1 in 10,000 or up to 12,000. So that public service announcement could have been a PKU announcement. So funding a public service announcement may be another way to get the message out.
Absolutely. Well, I hate to say it, but we're run out of time. Jane, it's just been a fantastic opportunity to talk. We may have to continue this another webinar. I very much appreciate all of you who have taken time to listen and appreciate
all those
Dr. Breck's dedication to this field and the patients. Our good friend the Reeses remind me that the official name of the fund held at the Children's Hospital of Pittsburgh Foundation is the Jane M. Breck MD PKU Fund at Children's Hospital of Pittsburgh Foundation. That's a mouthful. Just Google it, you'll find it. And we definitely appreciate your willingness to do that.
I wanted to thank everybody who's sent in those questions. They were very good questions.
Oh, there's never an opportunity to let the conversation lag with a topic like this. So thank you very much all of you for watching this webinar. And if you're watching it, or if you know somebody who's missed it, it will be archived on the CRDT website. So pass along the word, and that will be available for later viewing. Thanks again for your attendance, and have a great rest of the Rare Disease Day. Go celebrate.
High five for you. That was a great, fun time.
Very much so. And with that, we'll say goodbye.